Hey guys, Nurse Mike here, and welcome to SimpleNursing.com. Before we get today's lecture started, please remember to access your free quiz and preview our cool, nifty new study guides, not here on YouTube. Click the link right up here at any time during this video. We'll make this super simple. Heart failure, think HF for heart failure, HF for heavy fluid. Since the heart fails to pump blood forward, and now heavy fluid backs up into the lung and or body. Now this is super deadly since the patient ends up drowning in their own fluid. Now for right-sided heart failure, think R for rocks the body with fluid, also called peripheral edema. And L for left-sided heart failure, think L for lungs, also called pulmonary edema. Now the problem here is the fluid, guys, so any weight gain, we have to think water gain. And on the NCLEX, big key word here, over 3 pounds in 1 day or 5 pounds in 7 days is very bad. Write that down. So words like new, sudden, rapid, or worsening usually indicates a priority patient. So guys, if the body gets rocked with fluid, we usually see edema or pitting edema, basically fluid buildup in the extremities, usually the lower legs. JVD or jugular vein distension, and even abdominal growth from that fluid buildup. Now this is called ascites, and even hepatomegaly or splenomegaly. Now left-sided heart failure, L for lungs, also called pulmonary edema. Now this one is more serious since it always affects our ABCs, the airway and breathing. So we always hear crackles, or what's called rales or rales, which is fluid buildup in the lungs. Now guys, this is not rhonchi or wheezes. Crackles sound a lot like this. Now 2 other key words for left-sided heart failure, guys. Write this down. Frothy pink or blood-tinged sputum, always a classic sign of pulmonary edema. And the 2 penias, so think P for pulmonary, like dyspnea, which is difficulty breathing, or orthopnea, shortness of breath while lying flat. Now a little side note here, guys, typically we have no chest pain with heart failure, unless the coronary arteries are clogged, but usually the NCLEX couples that with heart attack and not heart failure here. Now speaking of worsening patients, guys, the NCLEX commonly gives those worst case scenarios. So key words, write these down. Sudden, new, worsening, or even rapid, guys. And that new pink frothy sputum or worsening crackles and even rapid weight gain technically is rapid water gain, or any even new peripheral edema. Guys, this is a huge emergency since the lungs are fluid filled, which compromises the ABCs. So write this down. The #1 treatment is always ide-ending drugs like furosemide and this B one. Guys, both end in ide, so think the body is dried. So any patient with worsening heart failure, we use the acronym HOPE for our NCLEX key terms. H for head of the bed, that's 40 to 90 degrees. Basically, we raise the head of the bed. This is called semi-Fowler's or high Fowler's, and even orthopneic position. O is for oxygen. P is for we push furosemide, and even morphine, which also decreases the workload on the heart. Now E is for ending all sodium and fluids, aka sodium and fluid restriction. So no drinking extra fluids, and guys, we're stopping all IV fluids. Now 4 common NCLEX questions for worsening heart failure, guys. Be sure to know these. #1, how does the nurse know if the treatment is successful? Guys, we're gonna hear clearer lung sounds with decreased heart rate. Huge NCLEX keywords here. Here's another one, guys. #2, always question any doctor order that wants to give fluids. Guys, even maintenance IV fluids. Huge no-no for that worsening heart failure. #3, when you're transferring a heart failure patient to another unit, guys, we're always reassessing those heart and lung sounds. Guys, reassess any patient that's transferred to another floor. In this case, worsening crackles in the lungs. Always those ABCs. Lastly, guys, #4, remember, sodium swells the body, so nothing from a package. That means no chips, no packaged foods, not even salad dressings or sauces or meats and cheeses. And here's another key word here, guys. Nothing over the counter. So no cold or flu medicine, not even those antacid Tums, or even acetaminophen, that Tylenol. But guys, we cover more of that in the treatment section. Now for the patho and causes. Usually not a big focus on the NCLEX, but it does show up a lot on nursing school exam. This will help understand the why behind the drugs like ACE inhibitors and diuretics, which is huge on the NCLEX. So let's understand how the body normally functions really quick. As you know, the veins vacuum deoxygenated blood back to the right side of the heart to get more oxygen from the lungs. And the left side of the heart pumps that oxygen-rich blood out to the body. This is what's called cardiac output, meaning oxygen-rich blood out to the body. Now, the number one risk factor is always hypertension, that high blood pressure, or that high tension on the heart. But usually heart failure results from anything that causes a dysfunctional pump. And this can cause fluid to back up, like in valvular malfunctions or even dysrhythmias like atrial fibrillation. And even all the cardiomyopathies, guys. Whatever the cause, the heart fails to pump blood forward effectively. And that's when things start really messing up. Now, more specifically for the NCLEX, left-sided heart failure develops from damage to the myocardial heart muscle, making the heart weak, causing a weaker pump. Usually from MIs, guys, where the heart muscle dies and now can't contract at all. So we commonly get heart failure after a big MI heart attack, or in ischemic heart disease before a heart attack, like in CAD or ACS, where plaque narrows the oxygen tubes or the coronary arteries, resulting in the left ventricle sort of suffocating from that lack of oxygen, which again results in a weaker pump, but in this case causing systolic heart failure, meaning a squeeze failure. Basically, the heart fails to squeeze blood forward. So fluid fills the lungs, causing pressure, and this is called pulmonary hypertension, which in result, the right side has trouble pumping blood forward. So left-sided heart failure commonly causes right-sided heart failure, aka cor pulmonale, or pulmonary heart disease. But right-sided heart failure can also be caused by diseases of the lungs, like COPD and even years of smoking, or obstructive sleep apnea. Guys, write that one down. Exams love to put that one under the causes of right-sided heart failure. Now, whatever the cause, the heart fails to pump blood forward. So now we have less cardiac output, meaning less oxygen out to the body. As a result, the kidneys get less blood flow and falsely think the body has low blood pressure, or basically low blood volume. So it mistakenly increases the already high blood volume by both stimulating the sympathetic nervous system to increase the heart rate and constrict the blood vessels, and also by initiating the RAS system, which retains fluid by locking the kidneys and constricting the blood vessels. So now we have two problems here: an already weak pump with increasingly high blood volume, leading to higher pressure. Oh snap! Now, a little side note that will be on the NCLEX. One of the main culprits in RAS, the renin-angiotensin-aldosterone system, is Mr. Aldosterone. We call him L for short, since he adds sodium and water to the body, which increases blood pressure, and he lets potassium out of the body and into the potty. So we end up giving drugs that either block or cut the communication lines to aldosterone. So drugs like prils, sartans, and even actone-ending drugs. Without Al in the mix, we don't add the water to the body, so we end up losing it in the potty. But now, we hold on to too much potassium. So the big NCLEX tip here, guys, write this down. All these drugs increase potassium, leading to high potassium over 5.0. So ACE inhibitors that end in pril, like lisinopril, guys, think P for potassium sparing. And also S's that spare potassium, so basically sartan, like losartan in ARBs, and S for spironolactone. Think S for spares the potassium. That's all we're mentioning right now. We're going to save the rest for the pharm section. Now, as far as diagnostic labs for the NCLEX and nursing exams, the only heart failure lab that you have to know is BNP. So write that down. BNP, also called B-type or brain natriuretic peptides. Guys, we think big bulging ventricles. So 100 and less is normal, over 300 is mild, and over 600 is moderate. Big keyword here, 900 and more is considered very severe. So the ventricle starts secreting it when they're being stretched out, or basically bulging out under all that heavy pressure. We can also do an echocardiogram, which measures both the size of the left ventricle and ejection fraction, or the amount of blood being ejected from the left ventricle in one pump. So 55 to 70% is normal, but anything less than 40%, big NCLEX key term, usually indicates heart failure. Now lastly, for severe cases, hemodynamic monitoring, aka the Swans Ganz Cath, also called PAC, pulmonary artery catheter. These guys measure CVP, central venous pressure. Now normally it's 2 to 8, So just say anything over 8 is not great. So if you get a question about a patient on hemodynamic monitoring, guys, let's just say the CVP is over 22. Now that's way over 8. The patient's basically drowning in their own fluids. So we give eye diuretics to drain that fluid from the body into the body. So remember, furosemide means the body is dried. Always an NCLEX favorite. Now as far as treatments, our #1 goal in heart failure is to drain that heavy fluid. So we do that in 2 main ways, with both drugs and lifestyle change. So let's start with lifestyle change. We use the acronym Dr. Beds. So D is for diet, that low sodium and low fluid. Big keywords right there for the NCLEX. Remember, sodium swells. So 2 liters of fluid, or about 8 cups, and 2 grams of salt or less per day. This means no fried foods like fried chicken or even French fries. And guys, we're choosing grilled chicken instead. Always an NCLEX key term on those select all that apply questions. No canned foods. Anything from a package is a big no-no, like chips, salad dressings, meats, cheeses, and even canned vegetables or even canned beans. And speaking of canned, we avoid all OTC or over-the-counter medications. They contain lots of sodium. So a big no-no, C for cold and flu meds, A for acetaminophen, basically Tylenol, A for antacids like Tums, and even NSAIDs like aspirin and ibuprofen or naproxen. Now some physicians will allow aspirin, but guys, on the NCLEX, it contains sodium. It's an over-the-counter drug, so be careful. Now patients return to the hospital over and over again because they can't avoid salt and end up in worsening heart failure. So guys, educate the patients. Sodium swells, avoid the sodium. R for risk for falls or orthostatic hypotension. Guys, NCLEX key term here, slow position changes when getting out of bed. B is for blood pressure and BNP. Guys, these numbers should not be increasing. So if they are, please notify the doctor or HCP immediately. E is for elevate the head of the bed and legs with pillows. Guys, we're talking high Fowlers to help the patient breathe here. D is for daily weights. Now this is probably the biggest NCLEX key term here, guys. Daily weights, not weekly. Be careful, the NCLEX will try and trick you, since weight gain means water gain. So anything over 2 to 3 pounds in 1 day, huge key numbers here. Or 5 pounds in 7 days, guys, it's very bad. We have to call the doctor or HCP. S is for sex, and yes, the NCLEX talks about sex. When is it safe? So the key word here, guys, is only after they can climb 2 flights of stairs without shortness of breath. And lastly, the last S is for stockings or TED hose to decrease that blood pooling. So guys, remember, remove daily and apply before getting out of bed. Oh, and never massage the calves in CHF patients. Big NCLEX tip. Now, 3 common exam questions from this section, and guys, trust me, they will try and trick you. So again, think HF in heart failure is HF for heavy fluid. And remember, sodium swells the body. So we avoid salt and we avoid water. So question number 1, a patient in heart failure who is constipated. What should or would the nurse recommend? So guys, walking is good, more fibers okay, stool softeners, that's good. Guys, but no fluid, no drinking extra fluid. Guys, we want to avoid the water. Now the second most common question always comes from the salty foods. So which food item should the heart failure patient avoid? Select all that apply. We're looking for no packaged items, so no chips, but fruits and veggies are okay. Now grilled is good, but not fries. Nothing that is deep fried. How about canned beans? Well, no guys, nothing that is canned or from a package, not even veggies. But white bread is okay. One of the most common priority-based questions. A client with chronic heart failure took cold medicine for her flu. So first off, no OTC, no over-the-counter drugs, guys, those contain sodium. She presents with new productive cough, with pink frothy sputum and worsening crackles. What action should the nurse take first? Guys, this patient is in extreme heart failure, meaning heavy fluid. So we have to give eye-ending drugs to make that body dry. So option number 2 is our best choice. Now, if you chose option number 4 to clock out for lunch, you bad. Okay, now for everyone's favorite topic. Wait for it, guys. Dun, da, 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 pharmacology. Always an NCLEX favorite here. Guys, we took over 10,000 NCLEX questions and organized only the most testable stuff here for you. So the content you see here is the content you need to pass. Okay, now our main goal here is to drain that fluid and help the heart pump blood forward. So pause your screen and write these names down. Please focus on the ending of the drugs, since the NCLEX focuses on this. They expect you to know what the drug does and how it can kill or harm the patient, which we'll cover right after this. Now, all these drugs drop the blood pressure and take workload off the heart, except Digoxin, aka Digoxin, who digs for a deeper contraction. It does not affect the blood pressure at all. It only decreases the heart rate. And he comes with toxic side effects, so we call Digoxin the toxin. So the big NCLEX tip here is everyone here can cause orthostatic hypotension, or low blood pressure and dizziness when standing. Everyone except Digoxin, since it does not affect the blood pressure. So we teach NCLEX key terms here. Write this down. Slow position changes. When blood pressure is low, we gotta go slow. Big on the NCLEX. Trust me, guys, they will try and trick you. So let's break these down one by one. First up, A is for ACE inhibitors and ARBs who act to lower the blood pressure only, guys, not the heart rate. Big on the NCLEX. Our first choice is ACE inhibitors that end in pril, like lisinopril. So we call it acylpril for the heart. We're talking low blood pressure, not the heart rate. Or think prils puts the blood pressure low. Now our second choice is ARBs, the angiotensin receptor blockers, which end in sartan, like losartan. So think sartan like relaxed man or retirement plan. Lowers the blood pressure, not the heart rate. So a question for you. Do we give prils and sartans if the heart rate is bradycardic or below 60? Well, guys, yes. ACE inhibitors and ARBs act to lower the blood pressure only, not the heart rate. So we only hold for low blood pressure. Now the mechanism of action is quite simple. Both ACEs and ARBs either inhibit or block the RAS system, which retains fluid, or in fancier terms, the renin-angiotensin-aldosterone system. So aldosterone is blocked from adding that sodium water in and letting that potassium out. So again, the big problem here is retaining too much potassium. Huge side effect. Now speaking of side effects, we just keep it simple. So just think ACE like an ACE inhibitor. A for avoid pregnant patients. These two are baby toxic. A for angioedema, swelling of the face and tongue, resulting in a huge airway risk. Very deadly. But guys, this only happens with ACE inhibitors, so just think prils puff up the tongue and not sartans. Big NCLEX tip. Now C is for cough, but again, only prils do that. And E is for elevated potassium, not vitamin K. We're talking potassium over 5.0. So think P in prils puffs the tongue and adds potassium. And S is for sartans. Sartans spare the potassium and are prescribed second after ACEs. Now we teach patients to avoid potassium-rich foods like fruits and veggies, specifically green leafy veggies, avocados, melons, and oranges, but even salt substitutes and liver. Now I didn't know the liver one until we did the NCLEX review. Now a quick NCLEX side note. Since potassium pumps the muscles, early signs of high potassium, we're thinking high pumps of the muscles. So key word here is muscle spasms. So with our ECG, we have high pumps with peak T waves and ST elevations. And any potassium imbalance, high or low, always the first action by the nurse is cardiac monitor. Huge NCLEX favorite right there. So again, prils and sartans are ACEs and ARBs. Remember the three A's. A for antihypertensive, we're talking low blood pressure, not heart rate, so slow position changes. A for avoid pregnant patients, not baby safe. And the last A is for adds potassium, aka hyperkalemia, over 5.0. Now a little side note before beta blockers, kind of big for pharmacology exams, something called first dose phenomenon. If you hear first dose or newly prescribed drug or the first time taking the drug, guys, don't leave the patient's bedside. Always assess for big side effects, so in this case, a big blood pressure drop. Okay, next is B for beta blockers, which puts the brakes on the heart, ending in LOL like atenolol. So think double L's means double lows. L for low heart rate and L for low blood pressure. So we always check both heart rate and blood pressure before giving. Now, pharmacology exams love to ask about the 3 negative tropics. So guys, beta blockers put the brakes on the heart. So negative chronos means less time, negative ino means less force, and negative dromotropic means less speed of conduction, which results in less beats. Now these fancy words just means that we get a decrease in resistance, workload, and cardiac output, which makes it bad for our patients in acute or that worsening heart failure. So for the mechanism of action in beta blockers, just think beta blockers block beta receptors in the sympathetic nervous system. Just fancy words for blocking beta 1 for 1 heart, and also blocking beta 2 for 2 lung. And since most are non-selective, or aka non-cardiac selective, we end up blocking everything. So we not only get a slow heart, but we also get narrowed bronchi in the lungs, basically called a bronchospasm. So we usually hold this drug for COPD and asthma patients. So to help you remember the most dangerous side effects, guys, write down these 4 B's here. Bradycardia and low blood pressure, we hold the drug. This is always on the NCLEX. So any heart rate less than 60 and any blood pressure less than 90 or 100 systolic. Guys, we don't give the drug. And since the drug affects the blood pressure, we always teach the patients slow position changes to avoid passing out, aka orthostatic hypotension. Next B is for breathing problems. Since beta blockers block beta 2 in the lungs, we get these bronchospasms, commonly heard as wheezing. So again, never give to asthma or COPD patients. Next B is bad for heart failure patients. It can worsen heart failure patients, guys. NCLEX keywords here, write these down. New edema, worsening crackles in the lungs, rapid weight gain, or even new JVD. All indicate a new heavy fluid, or basically worsening heart failure, which is a big priority. We always report these key words, always new or worsening findings, to the HCP, or basically to the doctor. Our last B is for blood sugar masking in our diabetic patients. So sugars below 70. Beta blockers commonly hide the signs and symptoms of low sugar, that hypoglycemia, hiding the cool, the shaky, the clammy, and even hiding that high heart rate. So guys, we want to monitor our sugars closely, since low blood sugar means low brain function, or basically hypogly, the brain might die. The next drug is C for calcium channel blockers, which calms the heart, dropping both the BP and heart rate, commonly ending in D-pine, Zem, and M-mil. So just think, D-pine declines the blood pressure, not the heart rate. But Zem in diltiazem is kind of like Zen yoga, relax blood pressure and heart rate. And A-mil in verapamil, calm and chill, low blood pressure and heart rate. So again, think calcium channel blockers calms the heart, controlling the couple, both heart rate and blood pressure. Yes, it lowers them both together, so we never give when the blood pressure is low or if the heart rate is low, less than 60. Now, how exactly does it do this? Well, calcium channel blockers block the movement of calcium. Pretty cool, huh? This relaxes the vascular smooth muscles, which leads to decreased vascular resistance. Now that's just fancy words for relaxes the blood vessels and takes the strain off the heart. So textbook, why you gotta be so fancy?
Yes, of course, the pseudostratified squamous epithelia.
So just like beta blockers, we get negative chronos, which means less time, negative ino, which means less force, and negative dromotropic, basically less speed of conduction, resulting in less beats. Again, these terms may come up on your pharmacology exams, but these exact terms never came up directly on our NCLEX review. Now what will be on the NCLEX are these key nursing considerations. So think CCB like a calcium channel blocker. Always before giving, guys, we count the heart rate and blood pressure. If the BP is less than 90 or 100 systolic, we hold the drug. Or if the heart rate is 60 or less, guys, we don't give the drug, except for nifedipine. He's the only one that declines the blood pressure. C for changes position slowly. Just like any drug that affects the blood pressure, we want to prevent fainting or that orthostatic hypotension. And B is for bad headaches, which are typically normal. Now a big test question, when do we hold the drug? So the magic numbers again here, guys, write these down. Heart rate below 60, and even blood pressure below 90 or 100 systolic, which in fancier terms, MAP less than 60. And we avoid big drops. So always slow or stop any IV drip that's dropping that blood pressure too quickly. Kind of like landing a plane, guys, we don't want to crash. We want a slow and easy descent to prevent crashing our patients. So for example, the NCLEX will give you a patient on an IV verapamil drip with a heart rate of 48. Guys, we want to stop the drip, any heart rate below 60. Or a patient on IV nifedipine or diltiazem with big drops in BP. Let's just say from 150 over 90, which drops to 120 over 70. Guys, that's a big drop, so we want to slow that drip. Just like landing a plane, big drops can kill the patient. So LPNs and LVNs notify the RN, and RNs will titrate or basically fix the drip. Okay, our next letter is D for digoxin, our cardiac glycoside. This guy has nothing to do with blood pressure, so we have no orthostatic hypotension and no slow position changes. He is our positive inotropic drug that gives a deep contraction or increases contractility. So think Digoxin, digs for a deeper contraction, usually given to patients in systolic heart failure or that squeeze heart failure to help with a more forceful contraction. And also it decreases the heart rate, aka negative chronotropic. Chronos meaning time, so negative time we get less beats per minute. But guys, caution, this is very toxic. So think Digoxin is a toxin. The top 3 NCLEX questions will always include our memory trick, ATP. A for checking the apical pulse for a full 60 seconds. If the heart rate is less than 60, guys, it gets a little risky. We don't give the drug. And here to help us out with the apical pulse location is Mr. Channing Tatum. Okay guys, focus, focus. The apical pulse is located left side mid-clavicular in the 5th intercostal space, basically between the ribs. You got it? Okay, good. Now, go ahead and go cool off. Now, T is for toxicity. Anything over 2.0 is huge. Early signs include vision changes, nausea and vomiting, anorexia, and even dizziness or lightheadedness. Guys, we want to notify the doctor ASAP. Huge NCLEX key terms. Now, another key term for vision changes include words like fuzziness or even blurred vision, even color changes, guys, and even, keyword here, difficulty reading. Now that one really surprised us in our NCLEX review. I was like, really, like vision changes for reading? What if you just have problem reading in general? Tricky, tricky. Not today, Mr. NCLEX, not today. No siree. Now a big test tip and side note about that big old kidney behind me. Guys, older patients with decreased kidney function are at higher risk for toxicity, our digoxin toxin. Since the kidneys are kind of like our washing machines that wash the blood, guys, broken kidneys means it can't wash the drug out of the blood. So remember, we have 2 kidney labs for our 2 kidneys, both BUN and creatinine. But the #1 kidney lab is, guys, write this down, creatinine. Any value over 1.3 means no PP, or basically over 1.3 means kidney injury. Huge risk for toxicity for any drugs. So guys, we monitor our elderly and renal failure patients very closely. Lastly, checking potassium level. Any low potassium below 3.5 increases the risk for digoxin toxicity. Now, this does not mean that digoxin can cause low potassium, like diuretics. Guys, low potassium only increases the risk for dig toxicity. Now the NCLEX will try and trick you. So again, digoxin does not waste potassium. So no, you don't need to eat more green leafy veggies or melons like when taking thiazide or loop diuretics that waste potassium. So guys, don't get tricked. Now to help you, a common test question. Here it is. Which patient is most at risk for digoxin toxicity? Guys, it's always either a client on potassium wasting diuretics, like those ending in "ide, like furosemide or thiazide, and even kidney failure clients with creatinines over 1.3. So our next D is for dilators like vasodilators, like nitroglycerin, commonly given for chest pain, but it also works in heart failure patients to lower the blood pressure. So remember the O's here. Think diolators like nitro. They open up the blood vessels to decrease the blood pressure by dilating the vessels and decreasing resistance. In fancier terms, it helps lower preload and afterload, which lowers the blood pressure. This results with more oxygen out to the body. Kind of like taking your thumb off a water hose, you relieve the pressure, and all that tension in the tube is suddenly decreased. In the same way, wider dilated blood vessels means less constriction and less pressure, or low blood pressure. Now again, our famous vasodilator is nitroglycerin. So think nitro makes the blood pressure low, or gives O2 to the heart muscle. Or just think nitro is like a pillow for the heart, rested and relaxed, decreased blood pressure. Now the top 5 names on the NCLEX are nitroglycerin, nitroprusside, hydralazine, here's a tricky one, isosobride, which is so tricky. Guys, write this down. It ends in "ide" and sounds so familiar to furosemide, the diuretic. So very simply, remember the O's in isosobride means it's a vasodilator similar to nitro. Guys, lots of O's. And the last one here is minoxidil. Now we only saw that one time out of 10,000 NCLEX questions we took, so it's not really common on the NCLEX. Now the killer precautions, the number one thing that shows up on the NCLEX and nursing tests is no Viagra. Drugs ending in afil, like sildenafil. Guys, it will kill. We're talking extremely low blood pressure. So our memory trick for afil is Viagra. It afils a certain male anatomy, or afil will kill. And speaking of low blood pressure, our 2 key numbers here. We stop nitro if the systolic blood pressure, the number on top, is below 90 or 100, or if we see drops by 30 points or more. And NCLEX keywords like confusion, agitation, even cold or pale or clammy, known as diaphoretic or dizzy, guys, these are all early signs of low blood pressure, that hypotension. So we always monitor that blood pressure with nitro. Now, normal side effects are always the 3 H's, usually always present after the very first dose. So headaches or hypotension, also called our orthostatic hypotension, and hot flushing or facial redness. Now, this is not an allergic reaction. These are common and normal. So teach patients slow position changes to avoid that dizziness and falling, again, called that orthostatic hypotension, and always check the BP before giving this drug. Now for the top 7 NCLEX tips on nitro. We're talking patch versus pill for angina patients. Guys, we cover that in our angina chest pain videos. So if you're watching that here on the membership site, you can find it under angina in the MI section. Okay, our last D is for diuretics, which diurese fluid or drain the fluid from the body and into the potty. This guy is the #1 drug we use for acute or worsening heart failure. Big NCLEX tip. So remember the D's. Diuretics decrease the blood pressure by draining the fluid or diuresing the fluid to dehydrate our heart failure patients with heavy fluid. Now we have potassium wasting and potassium sparing diuretics. Potassium wasting ends in "ide" like furosemide or hydrochlorothiazide. Both rhyme with dried. But again, be careful, not isosorbide. That's a nitrate, guys. The NCLEX will try and trick you. So remember the O's in isoso make it a vasodilator, similar to nitro. Now loop diuretics like furosemide and torsemide are the first drugs we use in acute or that worsening heart failure. So NCLEX keywords like worsening crackles, new edema in the legs, and even rapid weight gain. Guys, we give ides to make the body dried. These guys work by blocking the reabsorption of sodium in the kidneys. So with less sodium retained, we have less swelling retained, and our patient is saved. Now, we only give potassium wasters if potassium is normal, between 3.5 and 5.0. Anything less than 3.5 is a big no-no, guys. We don't give the drug. So we encourage our patients to eat melons, bananas, green leafy veggies, and even liver. And a big no-no here, we avoid licorice root, which lowers potassium, like those found in black licorice candy. That's a common select all that apply question. So just remember the double L's here. Licorice lowers potassium. Now, potassium-sparing diuretics, S for spironolactone, just think S for spares the potassium. Just like Prils and Sartan, this spares potassium too. But instead of blocking the angiotensin, this guy blocks aldosterone directly to let fluid out of the body and into the potty. And it ends in tone, so think it blocks aldosterone. Since spironolactone spares the potassium, we teach patients to avoid those potassium-rich foods, guys. So we don't eat those green leafy veggies, those melons, avocados, and we avoid that salt substitute. And again, any potassium abnormality, the first nursing action is to place them on a cardiac monitor. Always asked on the NCLEX and exams as a priority intervention. Lastly, since potassium pumps the muscles, NCLEX keywords like muscle spasm and even muscle cramps, this indicates a potassium problem. Even words like weakness or paresthesias. So with potassium wasters that lower potassium, think low pumps in the heart. We get flat T waves and ST depression. And also this little weird U wave. Now a little side note, if you have to replace potassium via IV, well guys, don't kill your patient. We never push potassium IV. This means instant death. We always give it IV bag over an hour or more, guys. Never 30 minutes and not even 45 minutes. 1 hour or more, typically 4 hours. And with our spironolactone, which spares potassium, we get high potassium. So think high pumps with peak T waves and even ST elevation in severe hyperkalemia. Now for other killer nursing considerations, guys, these three show up a lot on NCLEX exams. So guys, before giving diuretics, always check the BP. B for blood pressure, you hold the medication for low blood pressure, anything less than 100 systolic. B for BUN and creatinine, the kidney labs. We always check before giving since it can hurt the kidneys by giving too much or too quickly. And again, the P for potassium imbalances. Since P pumps the heart, we always put the patients on the cardiac monitor. Then we watch for muscle spasms or cramps and even weakness and paresthesias. Big NCLEX tips. Now finally, 5 general diuretic NCLEX tips, always on SATA questions. Number 1, take in the morning, not at night. This med drains fluid, so we don't want potty breaks all the time during the night. Second, this med makes patients dizzy, so slow position changes to avoid fainting, aka that orthostatic hypotension, also called postural hypotension. Third, daily weights, not weekly, but daily. Always reporting 2 to 3 pounds or more. Remember, weight gain usually means water gain, so maybe we need to increase their dose. 4 is risk for sunburn, so just use sunblock. And finally, low sodium diet, since sodium swells. So guys, again, no chips, no fried foods like deep fried chicken or even deep fried ice cream, definitely no French fries, and even no canned foods or packaged foods like cheese, wines, meats, and even fast food. And again, avoid those over-the-counter meds like can. So guys, cough and flu meds, antacids like Tums, acetaminophen like Tylenol, and NSAIDs like ibuprofen and naproxen. Guys, all these contain high amounts of sodium, which swells the body. Now a little side note about furosemide, our loop diuretic. We already know it's the #1 drug for worsening heart failure, right? But caution, if given too fast, it can be ototoxic, meaning ear pain or ringing in the ears called tinnitus, and even hypotension, that low blood pressure. But guys, not bradycardia, never low heart rate. And if given too much over the long term, it can cause nephrotoxicity, meaning kidney toxic, with high BUN and high creatinine. So always check the 2 labs to protect those 2 kidneys. And as you know, hypokalemia, that low potassium, below 3.5 for those long-term doses. Not usually affected by fast administration. All right, guys, that wraps it up. Now, don't forget to see our 8-question cardiac quiz and test your knowledge in our quiz bank. Thanks, guys. Thanks for watching. For our full video and new quiz bank, click right up here to access your free trial. And please consider subscribing to our YouTube channel. Last but not least, a big thanks to our team of experts helping us make these great videos. All right, guys, see you next time.